Let's begin with the lecture, and our today's lecture is the malaria. So the diagnosis of malaria. For the diagnosis of malaria, we need to do the complete blood count. Complete blood count help us in the diagnosis of malaria. The other diagnostic test will be the microscopic examination of the blood smear that gives us different types of plasmodium causing the malaria and any special features associated with those different types of plasmodium. And then we will also perform PCR or polymerase chain reaction test. So the diagnosis depend on the complete blood count, microscopic examination, and polymerase chain reaction test. The standard method for diagnosis, so one by one now we will discuss the lab microscopic examinations, different blood tests, and then polymerase chain reaction. So first, the standard method for the diagnosis, we can take the thick blood film and thin blood smear. So both thick and thin blood smears are used for the diagnosis. So first, the thick blood film. Thick blood film of plasmodium falciparum. You see this is the thick blood film, and that's how the trophozoites appear of plasmodium falciparum. These are the trophozoites. Then we have the gametocytes. So thick blood smear, we see the trophozoites of plasmodium falciparum, and these are the gametocytes of the plasmodium falciparum. So gametocytes and trophozoites. Then the plasmodium vivax, we have again, this is the appearance of trophozoites of plasmodium vivax. These are the schizones. These are the schizones of plasmodium vivax. And then the gametocytes of the plasmodium vivax. So you can see the thick blood film is also very, very helpful in the diagnosis, and it gives us different trophozoid, gametocyte, schizones, and you can clearly see the difference of these characters in different plasmodium falciparum vivax. So you can very easily differentiate between them. Then the plasmodium ovale, which is another plasmodium causing malaria. These are the trophozoites in the thick blood film, trophozoites. Then the schizones, these are the schizones. And again the gametocytes. So this is in the plasmodium ovale. Then we have plasmodium malariae or plasmodium malariae trophozoites. You can see in the plasmodium malariae. Schizones in plasmodium malariae, and these are the gametocytes. So all these plasmodium we can very clearly differentiate on the basis of thick blood film, and we can see the trophozoites, schizones, gametocytes that help us to find out the diagnosis, what is the causative agent of the malaria, or whether the patient has the malaria or not. Next, thin blood film. One was the thick blood film. In the thick blood film, you see very clearly, we can see the trophozoites, gametocytes, and the schizoid. But as compared to thick film, thin blood film will also give us the appearance of different blood cells or blood components also. So plasmodium falciparum, here you can see these are the young trophozoites, and the thin film now, that's the thin film, and that clearly give us the difference between the thick film and the thin film. So these are the young trophozoites. Old trophozoites now, little old trophozoites, not the young. These are the old trophozoites. And then we have the pigment in polymorphonuclear cells and trophozoites here. Next, the thin film of, again, plasmodium falciparum. We have the mature schizoids. These are the mature schizoids. Female gametocyte. Then we have male gametocyte. Now, the thin film of the plasmodium vivax, young trophozoite again, the young trophozoite of the vivax, old trophozoite here, these are the old trophozoite of the plasmodium vivax. Then these are the mature schizoid, these are the mature schizoids. Next is the plasmodium, again falciparum. We have female gametocyte and the male gametocyte. Next, the test is the plasmodium falciparum HRP2 dipstick or card test. This is another test used for the diagnosis of the malaria. These are the different pictures and what they represent on the dipstick or card test. We can see here, this is the anti-analyte epitope 1 IgG linked to gold. Then we have anti-analyte epitope 2 IgG, anti-mouse IgG, FC IgG, and then we have analyte. That's the sticks and how the reaction will appear. If the result is positive, we will have 2 lines. If the result is negative, we will have 1 line, just as a dipstick test of urine dipstick, the pregnancy dipstick. Then we have the test for the strep throat test. All these tests are on the basis of 2 lines positive, 1 line is negative. So before the use, this is we have the stick. On this, if we can see here, we have the anti-analyte epitope 1 IgG linked to gold. Then we have the anti-analyte epitope 2 IgG, and this is the anti-mouse. And these these green dots here, these are the analyte once it is mixed with the strip. So before use, that's how it appears. Once the analyte containing sample is added, so this is the analyte. So once the analyte is added, and this is the positive result, that is 2 lines, and then we have the negative result with 1 line. Here you can see the analyte is present. Here we don't have analyte, so it's the negative result. Next, plasmodium, LDH, dipstick or card test. These are all very rapid tests that can tell us rapidly whether the patient has malaria or not. So in this plasmodium, LDH, dipstick or card test, that's how the rapid malaria test strip looks like. These are the components one by one. This is the sample. Usually a drop of blood from the fingertip is obtained and it's put on the strip. This portion here, that's the anti-falciparum antibody, first line. Then we have anti-malaria antibody, all types other than anti-falciparum malaria, plasmodium falciparum will be with this line. So if this line shows us the changes, then it's the malaria caused by all the other factors other than the falciparum. Then we have, this is the control antibody. So we have the control anti-malaria antibodies and anti-falciparum antibody, and then the drop sample is placed. So these are the components of rapid malaria test, RMT. And this is the absorbent pad. If the control turns, this is the negative result, no malaria. If the control and the anti-malaria antibody turns the color, this is non-falciparum malaria. If the control, anti-malaria and anti-falciparum all change color, then this is pure or mixed infection with plasmodium falciparum. And if the strip shows only one, not control, is not changing the color, that means that strip or that test is invalid. So that's the rapid malaria test strip, very easy, quickly perform in the clinic, in the office, and this tells us whether the patient has malaria, whether it is mixed or pure plasmodium falciparum, or it's the other type not including plasmodium falciparum. Next, the other test for the diagnosis, we have a microtube concentration method. In this microtube concentration method, this is used for the falciparum malaria. On top of the tube, we have the plasma layer. Then we have below the plasma layer, the platelet layer. And then in the platelet layer, below the platelet layer, we can see these are the gametocytes. Then we have lymphocyte monocyte layer below the platelet layer. And this is the, below that is the granulocyte layer, and then we have red blood cells. So in the microtube concentration method, blood is taken in the tube, and usually the red blood cells which are heavy, they come to the bottom, they settle to the bottom, and then we have another layers present. On top is the plasma layer. Below the plasma layer, plasma is the liquid portion of the blood which comes on the top, and then the red blood cells come to the bottom. Below the plasma layer, we have platelet layer, then we have the lymphocyte layer, granulocyte layer. So plasma, then we have platelets, then we have lymphocyte, monocyte, granulocyte. And if we see the gametocytes, male and female gametocytes in between the granulocyte and the lymphocyte monocyte layer on the microtube's concentration test. Then it's the test diagnosis of the malaria caused by the plasmodium falciparum. And also we see the schizons in the granulocyte layer. So that's the microtube concentration method for the diagnosis of malaria. And these are the mature trophozoites. So all these mature trophozoites, schizons, gametocytes, we see in between the layers, which are the platelet layer, monocyte layer, lymphocyte layer, granulocyte layer. We can see the gametocytes, schizon, trophozoite, and that helps in the diagnosis of the malaria. And these are the layer of the red blood cell where we can see the ring forms or immature trophozoites. Immature trophozoites are also at the bottom where we have the red blood cells. So this is the microtube concentration method. Once the blood is in the tube, microtube, small tube, capillary tube, it divides into different portions, plasma on top, red blood cells in the bottom. In between we have platelets and the white blood cells, and in there we can see the gametocytes, schizon, trophozoites, and this is very helpful in the diagnosis. Next, some lab findings in the malaria. We have the, it can be normochromic, helps in the lab find the normochromic, normal hemoglobin level, normochromic. It can be normocytic anemia. So normochromic, normocytic anemia is present. We know there is anemia in malaria. Malarial parasite attacks the erythrocytes, it attacks the red blood cell, cause destruction of the red blood cell, and it can cause anemia, which is decreased in the hemoglobin level, decrease in the red blood cell, and it can be normochromic, normocytic anemia. Monocytosis, lymphopenia, decreased in the lymphocytes. Eosinopenia, decreased in the eosinophils. Reactive lymphocytosis, reactive lymphocytosis, increased in the lymphocytes, which is reactive, is also present. Increase ESR or erythrocyte sedimentation rate. Usually ESR is elevated in the infections. Different infections cause elevated erythrocyte sedimentation rate. So ESR is also helpful. Plasma viscosity. Viscosity is increased because of the destruction of the red blood cell. There is viscosity is affected, plasma viscosity. So all these are different lab findings which help in the diagnosis. We have lymphopenia, monocytosis, eosinopenia, ESR, normochromic, normocytic anemia. Some other lab findings: high acute phase proteins, levels of antithrombin 3. After the level of antithrombin 3, then we have there is prolonged prothrombin time, and also partial thromboplastin time. So all these changes are mainly due to the problem in the clotting or coagulation, changes in the platelet levels caused by severe hypothrombocytopenia. So prolonged prothrombin time, partial thromboplastin time. Then we have severe thrombocytopenia present. Platelet count is 105 per ml. So very, very low platelet count is present. Level of C-reactive protein. Then we diagnosis or lab findings in severe malaria. In severe malaria, there is metabolic acidosis. Acid level is increased. There is metabolic acidosis. There is low glucose level, hypoglycemia. Low sodium level is also present. Low bicarbonate, low calcium, low phosphate, low albumin. So all these things are getting low and low. We have the picture, if you remember, in the malaria one, when we talked about the findings and complications caused by malaria. It attacks the erythrocyte, it attacks mainly the red blood cell, and it attacks the hepatocytes, liver. So all these factors contribute to all these different abnormalities or findings we find in severe malaria. Low sodium, low glucose, low albumin, low bicarbonate, low calcium level, low phosphate level, and we have increased lactate because there is metabolic acidosis. Lactic acid level is increased, there is increased lactate. There is also increase in blood urea nitrogen because of the effect on the kidneys. There is increase in the blood urea nitrogen level. An increase in creatinine. Both creatinine and blood urea nitrogen are increased because of the effect of on the kidneys, and there is decrease in glomerular filtration rate, and this cause increase in the level of blood urea nitrogen and the creatinine, and both these are very toxic substances. They can cause toxemia, they can affect the brain, and the patient can be in the very, very serious condition. Also, there is increase in the level of urate. There is increased muscle and liver enzymes are present. So all these are the findings in severe malaria: decreased sodium, decreased albumin, low glucose, low bicarbonate, calcium, phosphate. So all these findings are present. Now the treatment of the patient. We have one patient which is uncomplicated malaria patient. Then we have patient with severe malaria, and one is the patient who have relapsed from the malaria. So these are these three pictures. We have patient with uncomplicated malaria, mild malaria, severe malaria, and patient with the relapse. The anti-malarial agents or drugs used for the treatment of malaria, if we go over the life cycle is in the plasmodium or mosquito, and then we have the human cycle. So life cycle has two stages, human stage and the plasmodium stage. And at the different stages, we can use different drugs, different anti-malarial agents, which will be helpful. So here, the bite of the mosquito, with the bite, the bite of the mosquito inject the sporozoids into the human. So with the bite, sporozoids are injected into the body. These sporozoids go into the hepatocyte or the liver cell. There they grow and they form a schizont, which is the second stage is the infection of the liver cells. So schizont, this takes about 5 to 6 days. So with the bite of the mosquito, schizonts are introduced into the body. They enter into the liver cell and they grow and form the schizont, and this schizont then release, and this then hepatocyte rupture or burst and release the merozoites. So sporozoids now change into merozoites, which are released from the liver cell. These merozoids then go into the erythrocytes here, and then in the erythrocyte they form trophozoid, then trophozoid again form schizont, and then the cells with the rupture of the erythrocyte, the trophozoids are released, but they also form gametocyte. The other way is they form the gametocyte, male, female gametocyte. And now these gametocytes are taken up by the mosquito with the blood meal, and there the cycle, plasmodium cycle start, and the fertilization occurs, zygote is formed, and then we have the transformation of zygote to ookinete. And then there is formation of oocyst and release of sporozoid. So that's the cycle of the plasmodium or malarial parasite cycle. Now we will look at what different stages we have different anti-malarial drugs which are effective in different stages. So here at the first stage we have anti-folates drugs. These are the anti-folates which function in the very initial phase when the sporozoids which enter into the human body with the bite of the plasmodium, they enter into the hepatocyte, and at that level we have anti-folates. Then in the second stage, when there is about to release of the merozoids from the hepatic cell, at this stage we can try primaquine, tefenoquine, and atovaquine. So all these quines are used in the second stage. Then at the level when the red blood cells are infected and there is conversion of merozoids into the trophozoids, at this stage we have artemisinin are used, artemisinin. Then we can use also quinolones and related drugs, antifolates, antibiotics, atovaquine, and pyronaridine. Then at the stage where gametocyte is formed, here we can try the primaquine. And then in the stage at the end where the oocyst is formed and this oocyst cause release of sporozoids, at this stage we can try atovaquine and tefenoquine. So these are the different anti-malarial agents used in the different stage of the cycle, and whatever stage of the cycle we use that drugs, we can get the benefit from those drugs. Now, uncomplicated malaria, which are usually the chloroquine sensitive strains, how we can treat that in uncomplicated malaria, and these are chloroquine sensitive strain. We treat them with the chloroquine, 10 milligram of base per kilogram stat, followed by 5 milligram per kilogram at 12, 24, and 36 hours. So a base 10 milligram per kilogram is given stat, followed by 5 milligram per kilogram at 12, 24, and 36 hours. Or we can give amodiaquine 10 to 12 milligram of base per kilogram for 3 days. If it is caused by vivax or ovale strains, we try chloroquine or amodiaquine, primaquine. If it is caused by severe plasmodium falciparum malaria, then we try artesunate 4 milligram per kilogram every day for 3 days. Or we can give sulfadoxine and pyrithamine 25 milligram per kilogram or 1.25 milligram per kilogram as a single dose. Or artesunate 4 milligram per kilogram for 3 days plus amodiaquine 10 milligram of base per kilogram every day for 3 days. Next, if it's the uncomplicated malaria caused by multi-drug resistant plasmodium falciparum malaria. So if the strain of plasmodium falciparum is resistant to different drugs, what will be the treatment in those uncomplicated malaria patients? We have artemether and lumefantrine, 1.5 and 9 milligram per kilogram twice a day for 3 days with food. Or we can try artesunate 4 milligram per kilogram for 3 days plus mefloquine. So these are the options of the drugs if it's the multi-resistant plasmodium falciparum malaria. Or we can try dihydroartemisinin and piperaquine, 2.5/20 milligram per kilogram every day for 3 days. Second line of treatment of uncomplicated malaria, we have quinine, 10 milligram of salt per kilogram TID for 7 days. Or we can give artesunate 2 milligram per kilogram every day for 7 days. One of the following three can be used: tetracycline, doxycycline, and clindamycin. So anti-malaria along with some antibiotics, tetracycline, doxycycline, clindamycin. This is the second line of treatment for the uncomplicated malaria. Or we can also give atovaquone and proguanil, 20 and 8 milligram per kilogram for 3 days with food. Severe falciparum malaria, what will be the treatment? Artesunate 2.4 milligram per kilogram stat intravenously, followed by 2.4 milligram at 12 and 24 hours. So it's now you see very severe plasmodium falciparum malaria. We give stat intravenous to control that, or we can give RT-mether 3.2 milligram per kilogram stat intramuscularly. Or we can give quinine dihydrochloride 20 milligram of salt per kilogram over 4 hours. So different treatment options are available. We have lot of drugs available for the treatment of the malaria. The important thing is the diagnosis should be early, before the complications occur or before it becomes really very serious or severe. Or we can try quinidine. So all these are the drugs used for severe infection. For severe malaria, we can also give the parenteral artemisinin. If it's available, we can give artesunate intravenous, intramuscular 2.4 milligram per kilogram at 0, 12, 24, 48 PRRT-mether intramuscularly, 3.2 milligram per kilogram and 1.6 milligram per kilogram. ACT combination therapy of plus primaquine, 0.75 per kilogram on day 2. If it's not available, parenteral artemisinin is not available, then we go for quinine, salt, and we can give quinine 10 milligram per kilogram every 8 hours plus doxycycline 100 milligram OD or clindamycin 10 milligram per kilogram twice daily for 7 days. So all these are different treatment options for the uncomplicated, complicated, severe malaria. We have quinones, we have artemisinin groups. So all these are used for the treatment of malaria. Now, if the malaria is present in pregnancy, then we should, if it's caused by plasmodium vivax, we give chloroquine for that. Until delivery, no primaquine, but weekly 300 milligram chloroquine. So during pregnancy, chloroquine is safe, so that is the drug that is used. For falciparum and mix, in the first trimester, in the first 3 months, we use quinine 10 milligram per kilogram 3 times a day plus clindamycin. And in the second and third trimester, we try combination therapy. Now, complications of the malaria, we have acute renal failure. All those findings we noticed, there is increased urate, increased blood urea nitrogen, increased creatinine level, all because of acute renal failure, because of decreased supply of oxygen due to all those decrease due to anemia or decreased blood. So we have acute renal failure as a complication. Acute pulmonary edema, there is fluid in the chest, fluid in the lungs that cause shortness of breath and respiratory failure. Hypoglycemia, decreased blood glucose level can occur, and then we have also some other complications besides these, some major complications. Chemoprophylaxis. Prophylaxis is the treatment performed to prevent the attack. So we cannot have malaria, we cannot get the malaria. So the chemoprophylaxis is very important, and it's recommended, especially if there is person traveling to the areas where the malaria is common. So chemoprophylaxis, we can use the Atova, quinproguanyl, and chloroquine phosphate. Then we have doxycycline, hydroxychloroquine sulfate, and mefloquinone. So all these are the drugs that can be used as chemoprophylaxis. Now, what steps we can take for the prevention of the malaria? Awareness is very important. How we can prevent the mosquito bites, wear these clothes which have full arms, it completely covers the body. That's very important. Use the mosquito repellent when you go outside. So this awareness is very important. How the patient with malaria will present, what are the findings, what are the first things we will be noticing. So awareness of malaria and how to protect it is important. Bite prevention, again, by wearing the clothes, so there is very less exposure, or by using the mospel or mosquito repellent. Chemoprophylaxis, I already mentioned some drugs that can be used for chemoprophylaxis. Diagnosis, we should diagnose the malaria early, and now, as we mentioned, there are rapid tests for malaria. So malaria rapid tests are available, so which tells us whether the patient has malaria or not. And then the emergency, we should know that this is emergency, complications are present, and if the patient is not treated properly, remember that malaria is on the top of the list among the infectious diseases that cause lot of mortalities or deaths. So very, very important that we should deal the patient properly, and we should try to treat before the patient reaches to the emergency level. So that concludes our topic of malaria, and in this lecture we talked in detail about the diagnosis of malaria. That's very important. What are the different tests we should perform to find out that the patient has malaria? And then we discussed in detail the treatment of malaria, whether it's uncomplicated malaria or it's severe malaria, or we also discussed the complications of malaria. So that concludes our today's lecture. Thank you for watching sqadia.com.